Wonderful. So we are going to now go to our next speaker. Next speaker is very well known to me. Our next speaker is Dr. Grace Muir. We call her Annie. So Dr. Annie is going to speak to us about being more active. And one of the things that always comes about in controversial literature is that, is running okay? Is jogging okay? What surface? How active should one be? What type of arthritis you should be more at? What advice are we going to give patients? And not just advice, but what therapeutic exercises we are going to perform that keep us going for a longer period of time. So Annie is Dr. Grace Muir, or Annie. She is the biomotion specialist and our running specialist at Rubin Institute. She's been with us for about 3 years, 4 years?
It'll be 4 years in
4 years.
June.
So in 4 years, and she has achieved a lot in that short period of time, and has really opened a new avenue of looking at our patients and bringing in more active young adults into our practice. At the same time, thinking about how to keep people active for a longer period of time. Because we all know activity keeps us going, both our mind as well as our physiology, including starts with walking, but walking is not the only thing. So I have asked Annie to discuss some of the general ideas about activity, about impacts, what kind of exercise, and after that, we will have a discussion about, people have a lot of questions about this all the time. So over to you, Annie.
Awesome. Thank you, Anil. Yes, I know Anil very well. I see him every day, and we work very closely. So you'll see him a little bit in these slides as well. A lot of his influences in here as well. So hopefully I can just follow the trajectory of maybe Joe Zini and eventually be a famous professor and go from there. So we've got a lot of good people on this panel. All right, let me go ahead and share my screen here. Okay. All right, so what I'm talking about today is basically osteoarthritis and activity and how we can be myth busters and movement gurus, because I think as physiotherapists, that is our overall job, and that's our biggest role for our patients, is to help kind of clarify some of the misconceptions out there and also be able to break down their movement patterns and give them the best possible direction when they're trying to be active, even if they have osteoarthritis. So again, I am the running and biomotion specialist at the Rubin Institute of Advanced Orthopedics over in Baltimore. And I work again with Anil, and I've had the pleasure of working alongside Sona as well, which has been a true honor. So I'm pretty close with a good bit of panelists here, worked alongside a lot of them. So what exactly are we talking about? Just to be specific, so everyone knows kind of where I'm focused. We're talking specifically at the knee joint, and we're talking specifically about a Kellgren-Lawrence scale of 1 or 2. So those are your more minimal osteoarthritis levels. If you think back to kind of the presentation that Joe talked about in terms of the bone-on-bone arthritis levels, this is not that patient population. This is the first 2 levels. So a minimal to minimal moderate level of osteoarthritis that we're talking about. All right, so a couple myths that I think our patients are told, and maybe we're told as well. One, physical activity increases the risk of developing osteoarthritis, which is a really common misconception about osteoarthritis in general, whether it be at the hip or the knee. And I've quoted a couple myth busters underneath, a couple research-based conclusions that they've done through research and literature reviews. So that's one myth buster that we want to kind of correct, because despite the common misconception that exercise has deleterious to one's joints, in the absence of injury, meaning you haven't actually torn your ACL or torn your meniscus or had some sort of structural trauma to your knee, there's no real evidence to support that physical activity alone increases your risk of developing arthritis. And I think that's really important to note, so that you can kind of reassure your patients, you know, you haven't had a trauma to this knee. Your knee joint looks pretty good as of right now. We're really safe and really want to promote physical activity for you, and especially to maintain your body weight and maintain your other health factors. Myth number 2, if you played sports growing up, you're more likely to get OA. Again, another myth. And again, this myth is tied to injury level. So yeah, if you played soccer or you played cricket, or you played a sport and you tore your ACL, or you tore your posterior lateral corner, or you tore your MCL, yeah, then you do have an increased risk of developing arthritis. But it's not the sport or the sports participation, it's the actual trauma to the joint that caused your increased risk of osteoarthritis, not the actual sporting activity itself. You also have to consider whether you're talking about an elite athlete or a recreational athlete. For most of our patients, not all of them, but most of them, we're recreational athletes. So we're not participating in a sport every single day for hours a day. We're usually doing it a few times a week. Hopefully we're getting a variability of physical activity and sporting. So you have to be careful about what you tell these patients. Now, if you're speaking of an elite athlete who has been doing this exercise or this type of sport for several years, it's likely that they have sustained an injury over the course of their career. And it's possible that they have actually had some arthritis because of that. Last myth I'm going to talk about: people with OA should not be too active. Again, this is another one that I'm trying to bust on a daily basis. I have patients all the time who are just so afraid to move because they're so fearful of making their osteoarthritis worse. So I would say I have this conversation almost on a daily basis with my patients of, you do not have to be afraid of movement. We just have to figure out what is the best movement for you based on a lot of different factors. And we're going to go through those today. So here's the real risk factors, and I apologize that this visual is a little bit blurry, but the real risk factors are: 1, do you have a vulnerable joint? And again, that vulnerability is based on, have you had a trauma to that knee joint? Do you already have a very severe level of arthritis? Do you have a history of ligamentous injury, things like that? Your age, so obviously the older that you are, the higher the risk. Female gender, females are actually at more risk of developing osteoarthritis than men. Nutritional factors, a genetic predisposition, so family heritage, genetics does play a role in your development of osteoarthritis, and then of course ethnicity as well. Then you can consider local mechanical factors that actually facilitate this progression. So you have some that are there whether you like them or not, and then you're going to have other factors that are going to make these more serious. So malalignment, a lot of like what we talked about today, a structural malalignment because those forces aren't being distributed along the right way. Muscle weakness, which I'll talk a little bit about here. Structural integrity of the joint, meaning is the meniscus damaged or is there any bone marrow lesions, things like that. Again, like Joe talked about, that meniscus is a shock absorber. So if they've had a meniscectomy or a meniscal injury in the past, then they've probably lost a lot of that shock absorption capacity. And then you have to consider, so these are all going to play into your role of developing arthritis. And then you have to consider obesity, which is actually the #1 modifiable risk factor to developing arthritis. So it's not physical activity, it's not even previous injury, it's actually obesity. That's your #1 modifiable risk factor. And then of course, joint injury. And all of these factors, these are the real risk factors of developing knee OA. So here's the truth about activity, and this is about running specifically. As Anil mentioned, I am a big runner myself. I am always trying to promote running when it is safe and possible for a patient. This is a nice visual representation of a study that they did about running specifically and its correlation to the developing arthritis. So if you take the general population that is sedentary, your risk of developing hip or knee OA is about 10.2%. If you take someone who's a recreational runner that's been running for about less than 15 years and running a few, they didn't have a specific number of mileage, but I think they averaged around, I believe, 15 to 20 miles a week, that you have about a 3.5% of arthritis. You have less than general population. But if you take it above that and we consider someone who's a elite athlete, again, who's been running for several years and several mileage, then that actual risk factor does go up to 13.3%. So the majority of, I think, runners live in this area where we're recreational runners. We're not running competitively. We haven't been running for, upwards of 15 to 30 years. So we actually have a lower risk of developing arthritis than someone who's just afraid to run in general. So when we're looking at a patient and we're trying to make a basis of our recommendations for that patient, what we want to think about is forces. So forces are what kind of dictate my decision in terms of what I'm going to recommend for my patient to do. So there's a couple things that impact forces. Body weight, for example, obviously someone's body weight is either going to increase with increased body weight, their forces, or decrease it if we can have them lose a little bit of body weight to overall decrease the joint forces acting on the joint. The other is alignment. Again, we talked about this. So a structural alignment that changes the way in which the force is distributed. So it changes that direction of forces. So we have to consider that as well. Coordination, so the patient's coordination, and this is a fancy way of basically saying how are they moving? Do they move in a way that is optimal for their joint, or are they having compensatory strategies? Is their movement pattern really off and actually creating excessive load on that medial compartment, and taking into account the static alignment with how they're moving so we can optimize where these forces are going. The environment, so there's two parts of this. The patient's internal environment, what is the knee joint actually, what are we looking at in the knee joint itself, the patient themselves, their health status, and then also the environment in which we're asking them to be active, and we'll go over that as well. The patient's strength, like Sona just talked about, the hip strength is extremely important for reflecting the mechanical forces on the knee joint. So looking at that patient's strength and whether they're able to distribute those forces effectively. And then finally, the activity. So what specifically are they doing and how much force does that create just based on the activity alone? So how do we mitigate our forces? There's things as a physiotherapist we cannot control. Body weight, we can encourage healthy lifestyle, but we can't control a patient's body weight for them. Their alignment, especially if it's structural, we have no real role over that structural alignment, at least not a significant degree. The environment, there's components, and you're going to see this in things we can't and things we can control, because there's some parts that we can't and there's some parts that we can. And I'm going to go over both of those in the next slide. Compliance, we can't make our patients do what we tell them to, unfortunately. That would maybe make their outcomes a lot better most of the time, but at the end of the day, it's the patient's decision as to whether they want to participate and be an active member in their care. I think there's strategies you can have to promote their participation, but at the end of the day, this is the patient's role and responsibility. It's their body, and it's their part to take a role in their own recovery. The things we can control, the activity, we can make proper activity recommendations based on where we think they are and what we think they can tolerate. We can set up an optimal environment for them, an external environment. We can help them get stronger, and we can help them move better, because that's kind of, again, what we do as physiotherapists. So this is a nice, cool graph that I found from a study by DeLima in 2012, and it looks at peak tibial forces with certain exercises. So I think it's interesting because, again, you'll see jogging is about 4.2 times the tibial force, or the body weight and tibial force. So yeah, it is pretty high, and I think that's where you get a lot of the discouragement for running in patients with osteoarthritis. But if you look down and you actually look at golf, and we always feel like we're really comfortable saying people can go play golf, at least in the United States we are, for that lead knee and that, with that golf swing, it's getting 4.4 times. So the peak tibial force is still really high for that lead knee for golfers. So to say, well, we want you golfing, or you can golf, but you can't really run, or suspecting that golf everyone's going to feel okay with, we need to consider all the different movement patterns of an activity. The same with tennis. If you're going through with a tennis forehand or a tennis serve, you're getting up to 4.2 or 4.3 times your body weight. So you're getting a higher peak force. That's not to say you can't do these things. It just needs to say that you need to prepare your patient for these activities. You need to know what the activity requires so that you can recommend them properly what types of things that may be hard to tolerate, or that they may need to work harder with accessory work to prepare themselves for these types of activities. And then there's other things that you can recommend that are really low force, things like the elliptical or power walking or a stationary bike, which is a great way to lose weight, gain range of motion, and continue to pump in synovial fluid to that joint. So there's a lot of recommendations here. You can use this table to kind of tell the patient, this is what you're looking at, and we can guide you to get you active, and we can look at how much force these activities are, so we can take that into consideration with your recommendations. This is a nice graph that I put together. the force continuum. So you can share this to your patients and say, you know, these are kind of, when we talk about low impact to high impact activity, this is that continuum we talk about. If you're going to be swimming, it's a fairly low impact. It's you know, really safe for that joint. If you're going to be, you know, running a lot more, it's a higher force. We might need to take a little extra time, a little extra care with you to make sure you can run effectively and move effectively before we get you up and running. And then, of course, things like, you know, Serena Williams, her front knee there, her left knee is taking so much force. So to say that, you know, we want someone to go back to tennis, there's a lot of things we need to consider with what they need to be able to do to produce and land and load that knee properly so that, you know, they're not set up for failure with their activity. Okay, so ensuring the right environment. This is one of the most important slides, and it's mostly the left side is the internal environment, because this dictates who you shouldn't be pushing with physical activity, who you shouldn't be throwing into an activity and saying, you know, it's a Kellgren one, it's really going to be fine. You can do really whatever you want. Not if they have active inflammation and not if they have actual swelling and things you can do. For example, a positive sweep test to dictate if there's actual peripatellar swelling going on and that they have active inflammation. You don't want to load that joint. You don't want to push that joint. That's someone that you want to work on, you know, maybe ice, NMES, quad sets, low load, but strengthening exercises that aren't going to put a lot of pressure on that knee joint and make the swelling and inflammation worse. Also, you have to consider pain, whether it be chronic or acute, and we treat those two things quite differently. And then again, if there's instability, so this could be an instability like a mid-range instability. It could be due to specific ligament laxity, or it could be due to a general ligament laxity, meaning the patient has, you know, an underlying condition that makes them more lax in other areas of their body as well. Maybe their foot causing overpronation, maybe their hip causing difficulty stabilization of their pelvic girdle. So all things to consider about the internal environment before you make a recommendation for your patient. And of course, is the patient healthy? So considering things like obesity, diabetes, heart disease, what medications they're taking, what their psychological state is, and kind of finding a way to tune their program to them as an individual first. In terms of the external environment, this is pretty straightforward. Things that we can change, the surfaces, if they're running uphill or downhill, you know, if we have someone walking or running downhill, it's going to increase that ground reaction force. So we want to kind of discourage that at first until they build up the right eccentric strength. If they're going to be a cyclist, we want to make sure they're properly set up for their bike fit. And some people may require additional help, things like, you know, proper shoe wear recommendations, orthotic consults, or even bracing to give them a little bit extra support. And again, that's all within our realm. So that's all things that we can be recommending to our patients. This is a quick slide. This is very broad in general, ensuring that there's enough strength. So if you find these mechanical deficits coming in, whether it be knee buckling, or you're noticing patellofemoral compression, or, you know, you're noticing that they've got a pelvic drop or a reverse Trendelenburg when they're walking. These are things that you should assess and that will likely be weak, and that's something that you could probably work on with the patient. As they get older, this patient here is actually a hip resurfacing patient. He's an ultra marathoner. He runs 100-mile races. He's quite impressive, and he's actually fairly old. I think he's in his low 60s, so not too old, but a little bit up there. And, you know, he's a highly active guy. His strength was excellent, and that's why he's able to run what he is. He also, you know, when I worked with him, we worked on gastrocsoleus strength, because as your patients age, you really have to pay attention to the gastrocsoleus, because that's what's propelling them forward. And that's what, you know, helps support the knee joint in one direction, but more so it keeps them moving forward without overusing other muscles that have more impact directly on the knee joint, like the quadriceps. Ensuring coordination. So this guy might look familiar to you, maybe not the tennis player, but the therapist. This is ensuring that you can have a patient who is properly coordinated for the type of activity that they need to be able to do. So you see Anil here is working on lateral stability. This guy had, I believe, Anil may have to correct me at the end, but I think he had a bilateral knee replacement. So this was actually correct. Okay. So this was actually after he had a total knee replacement, and he wanted to get back to tennis. And we can make these recommendations and say, yes, you can, because you can perform at this level, we can assess this, and we can make sure it's safe for you. And that's exactly what Anil did with this patient. We even added resistance, we added, control, looking at his knee control, things like that. So you're looking for movement faults with coordination. It's one of the biggest things that we have to pay attention to. And for these, for these different activities, whether it be walking, running, tennis, golf, these are just a couple things that you really want to pay attention to, because these are where you're going to see these compensations come in, and they may be subtle at first, but I think, like we learned in some of the slides before, we are sometimes we should be the first people that these patients see before they even need the knee replacement. So can we delay? Can we even keep them from getting a knee replacement? Because we can look at these activities, can we look at how they're doing these activities, and then can we make recommendations to them to better load their joint? This is a very busy slide. I'm not going to read through this whole thing. But again, these are movement faults that we notice, whether it be knee buckling, hyperextension, pelvic drop, patellofemoral compression, dynamic valgus, anterior pelvic tilting, or pronatory collapse. These are things that, okay, if I see this, I should assess this. I should focus likely on this, depending on what I found in my assessment. Again, this is a general guide. This is not always the case. This is not a specific patient specific guideline. These are, general ideas to think about as you're moving through with a patient. And then a couple of things you can try, different exercises, things that I like. And then there might be accessory things that you need to consider. So maybe someone's pronatory collapse is so bad that no matter how much foot doming or foot core exercises you do with them, if you get them with a higher plyometric activity, they're still diving in. And maybe that's when you need to come into consideration of orthotics, or maybe something like, adding in a taping technique or a bracing technique to provide additional support. That might be something that you use in conjunction with your therapy. So what do your patients really need? This is the second and last part of my presentation, is they need a guru. So they are looking at you and they are asking you, what are they allowed to do, how they can do these things safely. I think patients are typically very frustrated because they've been told a million different things and they are afraid of moving. And we are the best people to answer these questions. So they need a movement guru, someone who's going to give them advice that is well-informed and that it can be catered to them specifically. This is a nice depiction of how many times your therapist sees you, or excuse me, how many times your patient sees you and how many times they probably see their physician. Now, this is based off my experience as a therapist in the United States. They're probably going to see patients. Let's see, Anil's picture on here is probably, I'm not sure how many times I copied and pasted it, maybe 50. But they're likely going to see you as the therapist or Anil as their therapist 2 to 3 times a week for 6 weeks, maybe. And that's if they see their physician once in the 6 months or in the year. So again, we are walking alongside these patients. We are seeing them multiple times a week, a lot of times, and we need to be giving them this advice in this direction. It is not completely up to their physician, whereas he does play a huge role, but they're seeing us, they're asking us. We are very capable and well-informed to make these recommendations. And if we recommend something that's not quite right, we're going to be there alongside them to adjust it. So I always stress to other therapists, this is right within your realm of capacity to give these recommendations, assess them and figure out what's best for them and walk alongside them as they move forward. This is one of my own patients. A very interesting story. He's an older gentleman. I think he's about 50 something. If you can tell when he's running, let's see if we get him down the hallway. So I was treating his right knee, myself and another therapist, one of my colleagues, Dr. Simeon Mellinger. You can see here, it's tough because his shorts are a little long. This right knee has a really bad position, a really pretty terrible alignment. Let's see if we can. He's in pretty much a structural valgus alignment, and you can kind of tell that as he's running. He's in horrible footwear, old pair of Converses. I had spoken with him. Yeah, there you can see it a little bit better. He was wearing a brace. We had spoken. He really wanted to be a distance runner. He wanted to run up to 6 miles 3 times a week. So this was a challenging patient for me because I didn't want to tell him I knew if I said, I don't think running is the best activity for you, he wouldn't listen. He had told me that up front, that he had been told that several times, and he was going to run whether I liked it or not. So what we worked on is we worked on setting him up for success for a lower mileage. So we had a couple conversations of, okay, can we get your expectations down to maybe 2 miles at a time, 3 days a week, and go from there and start there. We worked on him with blood flow restriction training because his quad strength was terrible. We got him a new pair of shoes. We fitted him for custom orthotics, and we got him a knee extension assist brace as well to jog with. So we set him up for all these things, and he was actually able to join a running group and started running 3 days a week without any pain. And he has been able to maintain a really healthy BMI because of his level of activity and his level of motivation. So is he someone that I really want running for a really long time? I do not. But we can set this patient up. If he's going to run regardless, maybe we can have a realistic conversation with what type of frequency and duration he's running, and then how can we accommodate what he needs to set him up for success on the knee that he has. So in summary, what I think our job is as physical therapists is give your patient a plan, make it specific. The steps to that is ask the patient what their goals are. That's the biggest thing. If they don't feel like they have a role in their goal determination, then they're going to be less motivated to participate. Know your patient's history, know this current health status of your patient, the current health of the knee joint itself. Assess the patient, analyze the patient, figure out, are these movement faults happening? Do they have these strength deficits that kind of coincide with those movement faults? Determine what is their current force and load capacity, what can they tolerate right now, and make your activity recommendations based on those answers, and then determine where they can go from there. What's the most we want them to be able to tolerate, and is there kind of an area where we don't want them to go too much? Like my patient in the last slide, I didn't want him to really be a runner, but he told me he wasn't going to stop. So I had to accommodate what he was going to do and see if we could get those expectations monitored a little bit more. Write a structured and clearly dosed plan. So give them things like what they should be doing for exercises, how much they should be running, how much they should be cycling, things like that for their own activity recommendations. And then assess the patient again, keep doing it. This is why we walk alongside them. We don't just give them a plan and say, well, good luck, we hope it works. We need to be available to our patients to come back and say, you know, this didn't work for me. I need some modification. This picture here is actually my father. He has knee arthritis, and this is him after he had asked me to create a custom return to running program. And this is him with his highlighted notes that he sent me as he was returning to running, a part of his weight loss plan. So I think my dad is a really good story because he was struggling with type 2 diabetes. He was 50 pounds overweight, and he had really bad knee pain. And so we worked together with basically modifying his physical activity, getting him back to jogging after he had done some cycling first, and working on some strength on this side. So I think, you know, you want to treat your patients like your loved ones. You want to care for them. You want to ask them questions. You want to work alongside them. All right. Any questions, Anil?
Yes. That was a wonderful presentation. I love the part that you're even treating your dad now remotely. I like that.
Yes, Anil knows my father quite well.
Yeah, I know him very well. Very nice guy. Question for you. I like the idea of looking at the knee collapse as one of the, because what I have felt clinically is that if you allow the knee to collapse, that's when those patients down a year or two will require a surgical intervention, or they're in so much pain because there is an introduction of shear force. There's a, I call it constitutional varus, where you may have a varus that is you're built in. That's how you're built. That's how you're cut. But then you have enough muscle control and ligamentous balance to maintain that posture and withstand the forces. And then you have this dynamic varus or valgus that occurs with time due to trunk position, ligament laxity, muscle weakness. And then that is a downhill slope. So what is your preferred method of identifying the varus, dynamic varus? Is it visual inspection? Is it more video analysis? What do you prefer mostly in clinical setting?
So in clinical setting, what I do first is I get them on the table and I look at their actual ligament laxity. So I'll do a straight knee varus valgus test. I'll do a 30-degree flex knee varus valgus stress. So you can expect a little bit of give in that 30 degrees. That's really normal. But if they have one side that's really giving, one side to side, and not on the other side, then you can say, okay, well, there's actually a ligament roll to this. If that's the case, then I do sometimes consider things like bracing, because you want to give a little extra support depending on the severity of that laxity. And then what I do is I get them off the table. I look at them in a squat form, like 10 squats in a row. And then I have them do a single leg squat, usually about 7 each side. And I look at both sides. And then I do an 8-inch step down test to look at that too. So, and then I look at hip strength. So I like to look at all those things first to say, like, okay, well, what does the actual knee look like? And if the ligaments seem very intact, very, kind of normal, not super lax, then I look at the movement pattern and say, okay, this is actually coming either from the foot as it pronates in, or it's coming from the hip because it's not able to maintain that knee position. And I use those functional tests to kind of correlate with the hands-on tests as well.
Very nice. That was very good. About orthotics, you said something about the collapse of the foot, the navicular drop in dynamic activities. What's your tolerance? When would you say that, oh, you know what, he's got a little bit of collapse, but that's fine. He can build it up. He can do the muscle. Or when do you call it when you see a total collapse of the foot when orthotics are needed? Because this is a very debatable question about, does everybody need orthotics?
Yes.
And if you're going to run, then what does the orthotics really do?
Right.
For running? Yeah.
Right. So orthotics. So I make orthotics at Sinai currently. I try to avoid making orthotics for people. The times that I think that they're really necessary is one, a lot of my female runners have a general underlying laxity. That they're working so much harder just to get some stability in their feet and in their pelvis, that to some extent I feel the orthotic just has to be there to help them. And that's because they have this underlying laxity generalized across their whole body. So that's one case when I really start to consider orthotics. The other consideration that I make is I put them on a trial program. So we work on foot core exercises in addition to hip strength and just control. But we might start them with like a taping trial. So for 2 weeks, we're going to tape their medial longitudinal arch, and we're going to give them a little support. And I use McConnell tape because it's denser, it's more structural than kinesio tape is. And if they're able to wean out of the tape and not have the knee pain anymore with a lot of the activities they did 2 weeks prior, then I think, okay, you probably don't need orthotics. If the second we take the tape away, even after they've built up the strength, maybe even up to 6 weeks, and they're still needing that support, then I'll consider the orthotics might be a good idea, because it's something that the tape is almost a window into an orthotic consult. So if the tape is effective, can it be a short term or does it need to be long term? And if it's going to need to be long term, then we're going to go with orthotics there.
Thank you, Annie. That was wonderful. Very nice presentation. I learned a lot. I learned a few things that I had not thought about. That's great.
Good.
So I just want to summarize we had a very thoughtful discussion. Don't advance yet, but that's okay. But remember this, that there are only 2 reasons why people come to us. Can you go to my slide and maximize it? Hello? Yeah, just stay there. Okay, I'll tell you to advance. So reduce pain and improve function. That's all they come for. Next slide, please. And I want to share this important discussion point about where is the knee pain? Where is it coming from? And this is a very small study of 2 orthopedic surgeons actually doing arthroscope on each other when they were awake. And they looked at, using a probe, they looked at pain. Where is the pain coming from? So let's go to the next slide. And the black areas are most painful areas. And if you remember Dr. Deepak Kumar talking about patellar fat pad, that's the most painful area in our knee joint. And ACL bundles and PCL bundles are painful, but the cartilage itself, the cartilage itself has no sensation of pain directly. It's the subchondral bone that has pain, and the posterior capsule of the synovium has a lot of pain area. So everything that is in black is painful. So when we treat our early OA patients, I think it's important to remember that most of their pain doesn't come from the joint itself. It comes from the periarticular tissues. And we as therapists have to manage the periarticular tissue really well. And that's where the value of manual therapy techniques, strengthening exercise, all of that we talked about, we have to go back to this slide. Next slide, please. So we have been focused on the varus of the knee. Every time, I was young and, when my grandmother got arthritis, she just got one X-ray of the varus of the knee. She had raging flexion contractures of both her knees. I remember that. But I never paid attention to that. But this is what we looked at. We looked at the X-ray. Then the doctor pulled out a prescription pad and prescribed some anti-inflammatories and said, you can have injection. And that was the end of her treatment in early 1960s and 70s. So is it just the varus deformity? So next slide, please. Next slide, please. So this is a raging valgus deformity. This patient cannot have a total knee replacement. And can we manage this patient with therapy techniques? So yes, we can. And this is no cartilage on the lateral compartment. This patient came to us many, many years ago. I think we have a 5-year follow-up on this patient. I personally have treated this patient. She had a flexion contracture. You can see on that X-ray, her knees doesn't fully straighten up. And she had a really bad valgus compartment arthritis. But next slide, please. But with proper management, and when I call proper management, everything matters. The manual therapy to get the knee straight mattered. Patellofemoral mobilizations mattered. Taping mattered. Bracing mattered. But in the end, she's now 5 years out and still no total knee replacement. And she can't, it's very difficult knee replacement when she has it. So even if Joe says that valgus deformity is so bad, 5 times worse than the varus, it can be managed. And I really believe that some patients who are willing to go through the trouble can still be managed with appropriate physical therapy and biomechanical intervention, even if they don't have cartilage. Because you unload their compartments. If you can unload their compartment, just like you unload the patellofemoral compartment, we can also unload the varus valgus compartment. Next slide, please. And this is my favorite. I've seen this many times. This is a clinical exam showing full extension of the knee. Joe talked about this, but they stand in flexion like this. Why do they do it? Maybe they have calf weakness. Maybe they have hip flexion contractions. Maybe their hamstrings are overpowering. Maybe their patellofemoral joint is in pain. We have to find out. But then, next slide. This is my test. I like this test the most common. This is I call it relaxed tissue tension. If you have this and your one heel is up, posturally this is going to be a problem. I don't need to examine the patient. I can just see it and tell that this is a problem. Next slide, please. And this is my gait analysis that shows that the patient has a varus, but also has a flexion. He comes in at 25 degrees of flexion in gait. Next slide, please. And this is how he walks. So he walks with a lot of knee flexion. So the only treatment that is required for him to get is straight. And I want to share this with you. This is since we are talking about Dr. Sancheti and the senior Sancheti, both are the founders, and the Dr. Senior Sancheti is the founder of Sancheti Institute, and Scientifica is hosted by Sancheti. I just want to share a little example of this. This Dr. Senior Sancheti started the Sancheti Orthopaedic Institute in 50s. And one of the commonest things he did for osteoarthritis patients was MUGA. It's called MUGA. He used to call it MUGA. At that time, what was MUGA? MUGA was osteoarthritis patients came with flexion contractures all the time, and severe ones, not like this. So he did a manipulation under anesthesia to stretch their knee out, put them in a simple wooden splint, and gave them a knee injection. And everybody was very happy. He called it MUGA. And I heard it from Dr. Senior Sancheti himself. So the value of extension in osteoarthritis goes a very important one. And I think we should all recognize that. And I think Dr. Deepak, as well as Dr. Josini, have emphasized it very well, that knee extension, in my opinion, and I'm being a little bold here, is that we have focused too much on varus valgus of the knee joint. What we haven't focused enough is knee flexion extension and the posture of the knee in extension. To me, the osteoarthritis is not a frontal plane disease, but a sagittal plane disease first, because that's how it starts and gets worse. And if we can manage that during that period of time, hopefully we don't get to the worst point. Next slide, please. Can we advance? I think you'll have to go outside the video and advance it. If you're having technical trouble, we can, hello, Sona, are you there?
I'm just trying to contact the person.
Yeah, this is how to advance the slide. I wish I could do it, but I don't have a problem. But you have to go outside the video and click on it. Okay, that's fine. We can continue the discussion. My next two slides were about rotation. So what I have felt in the gait lab analysis, as well as my clinical practice, is that there are good combinations and bad combinations. And the bad combination for osteoarthritis is external rotation of the upper area, meaning femur, with interrotation of the foot. That combination is a bad combination for varus knee, meaning external rotation of the hip joint and an internal rotation of the ankle or the thigh foot axis is a bad combination. And opposite that is bad combination for valgus, or the patellofemoral joint and valgus loading is the rotation. Can you advance my slide, please, one more time? I just want to show you that slide. Keep going. So this was about, we don't like knee flexion contractures. Next slide, please. And this is about the patellofemoral pain. Can this be a problem? And next slide, please. Keep going. Yeah, let's stop here. So this is what we have seen in the gait lab, and clinically have seen many patients like this, is the malrotation. So on top of the varus valgus, you now have a rotational syndrome, and you have the flexion extension syndrome. So when we examine a patient, we should see all the planes. We should see the flexion extension as elegantly shown by both Deepak and Joe, and also talk about full flexion, extension fully, talk about the varus valgus. It's important. I'm not saying that we discount it, but then also look at the effect of rotations on the knee joint. I think that's important. Why do I feel that is important is, next slide, please. Because there are a lot of dynamic factors that as therapists we can change. For me, a patient with patellofemoral pain with a valgus loading, I look at these things. I look at the hip flexor and adductor tightness, medial hamstring tightness, gluteus medius weakness, because that will lead to malrotation of the femur over tibia, TFL, IT band tightness, and pronated feet. So I think to put it all together, I thought it was important to bring up the rotation point, because Sona also showed very elegantly that there is some rotator deficits, interrotation deficit, external deficit that happen in the knee joint. So that's what I have clinically seen. So you can stop sharing my slides, I think, and we can just go to camera view now, and everybody can be on. So first of all, I want to thank all the panelists for their wonderful presentations. I really enjoyed your presentations, and I have some remaining questions for you. Joe, you alluded about female versus male patient and the adipose tissue concentrations. And what I have seen in the literature reported that the female gender has a specific increase in what we call IMAT, the intramuscular adipose tissue of the quadricep muscle, while as males have more SCAT, or the subcutaneous fat tissue, subcutaneous fat. The female gender that has the IMAT has significantly weaker quads and lead to more arthritis of the knee joint. What's your findings, and where do you see this going in terms of Because I have a friend at National Institute of Aging that has actually shown that with training, with just simple training, you can change the IMAT concentration of the quadriceps for a female patient into more muscle and less fat. They've actually done cross-sectional CT scan studies to show that. What do you think about that concept?
Yeah, so I think that's an emerging area. It's only been in the past couple of years that we've really identified some of these differences, these like gender and sex-based differences in the pathway to OA. So I'm interested to see what comes of it. There's not a lot of information out there to say, we know that muscle strengthening is going to improve biomechanics. We know that the muscle strength is a protective factor in developing OA. So it'll be interesting to see if there's a targeted differences between the sex in terms of how the muscle responds to training, and whether it's an increase in the overall cross-sectional area or an actual change in the morphology of the muscle in these patients. But we don't know yet.
Okay, thank you. Deepak, Dr. Deepak, I have a question for you. One of the things that I was interested when I said that you use modalities before treatment so that you can do manual therapy. One of my challenges is there are a lot of modalities that are promoted in our profession. You do the laser, do this, do that. And instead of being active therapists, we become passive therapists, meaning that we rely on modalities. What's your sense of, from Indian perspective, as you teach a lot of people and influence a lot of people's mind, what is your sense on modalities being used primarily for OA, osteoarthritis of the knee? What is your sense on that? What would you say about that?
Can you hear me?
Yes. Yes.
Yeah. Okay. As far as the electrotherapy is concerned, to be very honest, and there are a lot of literature on it, that its majority of them are placebo. Okay. But then to my therapist, I say even placebo treatment is a treatment. It's not like placebo treatment is not a treatment. So when patient comes, okay, we do use electrotherapy. It's not that we don't use, but the way the therapists think that if they're giving the electrotherapy, that will increase the blood circulation. Excuse me, for the OA knee, it's not the blood circulation, because inside the knee joint, there is no blood supply. It is the synovial fluid that moves and give nutrition. So it is the movement, it is the strengthening exercise which is going to be the management of the OA knee, not increase in blood circulation inside the knee joint. That's a pathological condition, that is hemarthrosis. Okay, so many physio, they think by giving electrotherapy, they are able to increase the blood circulation of that area, and there is enough literature that says no, there is no significant increase in blood circulation. So I believe electrotherapy is more of a placebo for osteoarthritis of the knee joint. But yes, still we do it. Like I said, we do the long wave or sometimes the ultrasonic, but that is basically for breaking the adhesions or taking care of the inflammation part of it, or the hot pack, just to prepare the patient for manual therapy. Or in case we need to give Russian stimulation for building up the vastus medialis or the glutes, in case patient is not able to understand what exactly it is, or they are not able to contract it very effectively, in that case we do use stimulation for that purpose. Other things we don't use. Laser, I'm so sorry, I don't believe. Every time they come out with the new machine claiming it to be more effective than the previous one, sorry, now I have stopped believing those vendors.
So you believe in some of the electrotherapy modalities for some of the physiologic effects that may or may not happen.
Yes.
But you don't really believe in the heating modalities that really change anything in terms of management of patient other than loosening the adhesion. Is that a fair statement I'm making?
No, for heat modality, I'm using for making it soft and supple, reducing the viscosity of the synovial fluid, if at all, some viscosity can be, and plus the pain gate mechanism, like we give it for a longer period of time. So yes, we do use pain gate mechanism for reducing the pain and the inflammation. Yes.
And then you always follow your patient after manual therapy with exercise prescription or
Always.
exercise.
Self-treatment is a must. Because I believe if you are treating patient for 5 to 10 minutes, then 23 hours and 50 minutes is doing nothing. It is
Yeah.
important to do the self home management so that, and nowadays, like in India also, the time is money. Okay,
Money.
people can't visit you on daily basis. The traffic and the busyness everyone is having. So it is important to teach them self treatment so that they just need to visit once a week or twice a week. Yes, earlier the practice was they must visit on daily basis, but now
Okay.
people don't want to come on daily basis.
It's not needed also. I don't think it's
Not needed.
needed every day. Yeah.
Absolutely, absolutely.
So Sona, you are from India also. So what is your practice pattern? I know you teach more, but what do you see as a practice pattern in India, and what your students, how do they are shaping up to be more manual therapists to manage chronic disease, or more modality based? How do you see the future?
Well, I surely hope it's not modality based only. So I guess as movement, I think we are movement doctors, all right, motion doctors, or improving movement and mobility as well as strength is going to be our very strong point, and I hope we stick on with that because at the end of the day, if mobility and strength can be regained in any of the joints, then I guess we are going the right way, whether you do it with manual mobilization or you pick up only a strengthening protocol or you have a mix of both. And I do practice in clinic. I do go to the clinics and I am guiding the students for clinical practice also. So we do have a mix of everything. So there are times when I use a lot of Mulligan, or I may use Maitland, or I can go in, but the strengthening remains always the mainstay, and also the mobility. So without doubt, as you had pointed out earlier, I try to get a straight knee first and then work on the knee flexion deficits. So first would be to get that 0 degree extension and have the patient comfortable. And I usually believe in strengthening the entire kinetic chain, as I just told. So right from the ankle toes, right up to the hip, and maybe sometimes the core in case that is weak. So the entire thing gets strengthened, and the patient is given home exercises basically in the strength deficits or the mobility deficits that he has. But surely, yes,
Thank you.
mix of everything and less of modalities.
Deepak, you raised your hand. You want to
Yeah,
add
I
something?
just want to add one line, like the modalities, if at all, modalities can change the physiology, not the physics of the knee joint. And OA knee is more of a physics, and we being physical therapists, we have to work on the physics, not the physiology. For physiology, there are medicine, there are so many other things. So modalities can change the physiology, not the physics, and we have to work on the physics.
Nicely put.
So the next question is for Joe and Annie. There's a lot of these patients walk with a flexed knee, but they don't have a flexion contracture, or they may have a flexion contracture, small degree. And there's a lot of talk about gait retraining therapy in terms of teaching the patient how to do it. What's your preferred method of training a patient to get that knee straight while they are walking, or at heel strike, they have a full extension or close to full extension at the knee, and they have appropriate loading response knee flexion? What's your favorite techniques for that? How do you do that? What would you tell the patient? I'm a therapist, I'm a new therapist, I'm a student, and I see a patient who has full extension or maybe 5 degrees of lack of extension, but I'm not using that while walking. So how do you train that person? What do you do?
Yeah, we do two things. So one of the things we do is we will record them. Usually in these patients, it's fairly obvious. I mean, the initial contact, it's an easy, discrete point in the gait cycle that you can pause the video and say, look at what your knee looks like. And this is what I want you to work on. I want you to think about landing on your heel. I want you to think about tightening up the muscles in the front of your leg, those sorts of cues. But I show them a video and see whether or not they're able to make changes with that. And the other thing I tell them is I also want when you're walking, I want it to sound the same. when someone walks with the flexed knee, you usually hear like a shuffling sound on one side and a louder sound on the other side. If they can listen as they are walking to make their sound symmetrical, that also tends to help reinforce the movement symmetries as well.
Annie, you want to add something to that?
Yeah, I do a lot of the same things Joe does. Usually I try to show them visually what I'm talking about. If I can give them that feedback in real time, that's ideal. Sometimes we're able to kind of project, we're able to film them in the sagittal plane and then project it in front of them so they can see themselves from the side, but while still looking forward while they're walking instead of trying to look at the side. The other thing in terms of exercise specifically that I do a lot of times, sometimes I'll throw in some, if it's really because of quad deficit weakness, I throw on the BFR and I throw on the NMES and I make them do single leg TKEs, like terminal knee extensions, or I'll make them do step ups with a terminal knee extension. So they just practice, all of it's done in front of a mirror. So they basically practice engaging their quad at a time when they're in single leg stance. And then we'll put them on the treadmill and we can actually, our treadmill goes backwards. So we can actually add the band for the TKE so they can practice holding on safely and then pushing into that band in that mid stance phase. So they can have this kind of tactile cue of like, this is where I push my knee to, and this is where I get my support. So same thing as Joe, just, we put in some bands as well.
So you talked about BFR. That's a new rage, all right? Everybody is using BFR. It's a common thing now, sports only. Most people, you don't dare to use BFR in older patients. But it seems like we do. I do, you do.
Yes.
So for everybody's sake, what Annie's talking about is this new technique called blood flow restriction therapy. You can strengthen the muscles at 25% of your 1RM. So at much lesser loads, you can actually recruit muscle fiber recruitment faster by arterial occlusion and a venous occlusion. And it's a very neat technique. What I like about it mostly is that not only it allows you low load muscle recruitment, but most importantly, it recruits fast twitch muscle fiber. And remember this, gait cycle is less than a second. So if you cannot get that quads to work in the final degrees of extension and get that quads to activate, and some people say vastus medialis obliquus has to activate, there's a lot of debate on that, but forget all that. Muscle recruitment of fast twitch fiber in a gait cycle happens in a short milliseconds, I think 25 milliseconds time. So in that quick period, patient has to go from fully extended knee to a loading response knee flexion of 20 degrees back to flexion again. How are you going to do that if you don't have that fast twitch activity happening? So training will only get you so far, but if you are weak in your muscles and you can't activate your fast twitch, then it's a very exciting area for strengthening those muscles and get the patient over that hump, especially a patient who has been inactive for a while because of pain or stiffness or whatever the reason is. So I like that a lot for patients, and Annie is a big user of it. So, and I like to use it also. It makes a lot of sense that for the first time we have a physiologic modulation of environment for strengthening the muscle. So I think it's a very exciting area of blood flow restriction therapy that people all should look at. Any comments on that, on Joe? Have you seen that work in your practice?
Yeah, we haven't used it yet, but again, it's an emerging science that I think is going to, travel from the sports realm and make its way into a variety of orthopedic conditions and even neurological conditions too.
So one of the things we didn't talk about is bracing, the knee brace. And we talked briefly about it. Our experience, we have gone through many brace companies. And in the end, if the patient is not going to wear them, they are all become a furniture in their house. And one of the biggest challenges is to get the patients to wear braces. And it's been very challenging. And most people who will wear brace will wear brace for a patient from Annie who wants to be active He has a slight buckle in his knee and he wants to protect his knee and they'll use it. But it's very difficult to get patients into bracing. What do you think, Dr. Deepak and Dr. Sona? What's your experience in India?
So basically, just wanted to butt in actually to just tell you that the time is really running short.
Okay.
So yeah, so I'm just getting little pokes from the organizers to really
Okay, that's fine. This will be the last question, and Dr. Deepak, you can answer it real quick, and we'll stop right here.
So you need to unmute yourself. Yeah.
Okay. So I saw those nice braces used by Annie in the video presentation, and I saw the same brace when you visited India during SIP conference in Mumbai. And unfortunately, those braces are quite expensive here, and not every patient can afford those braces. But yes, sometime when a few patients have like purchased it through their relatives, or they could afford to buy those braces are effective and helpful. They have reported that they have been like they get a good result, but unfortunately not everyone. So we are trying to manage patients with the help of taping, especially taping and the strengthening exercises.
Okay.
And I do a lot of McConnell taping and correct the alignment of patella and all those things. So this is what we do, either the brace or the taping. This is how we manage.
Okay. So I want to thank organizers for letting me moderate this session. And I enjoyed doing it. And I want to thank all the panelists individually, Dr. Deepak Kumar, Dr. Josini, Dr. Annie Neurer, and Dr. Sona Kolke for being the panelist. And I enjoyed doing this. And we will now say goodbye. Thank you.
Yes.
Thank you very much. Thank you for
Thank you.
Excellent.
Good
Thank
night.
you,
It's been a
everybody.
very
Good night,
lively and a
everyone.
nice talk, and I'm sure people are going to benefit from this panel discussion. Yes. So good night to everyone. Yeah. Good morning to the
night,
ones in the other side of the world. Yeah. Bye-bye.
Bye-bye.
Good night.
Good night.
This is an exciting opportunity for both practicing physiotherapists as well as graduating or master's level students in musculoskeletal medicine to get a comprehensive hands-on workshop. To register for the course, easiest way is to just email us at alld.pune@gmail.com. Once again, it's an exciting opportunity of hands-on course all day long, 4 days with post-test, and I hope to see you all there.